share your
Sorry, okay.
presentation to be visible to us. Yes, please. Yes, thank you very much.
Our patient is 39 years old female patient, presented with dropping of both upper eyelid. 3 years ago, it was gradual onset, was progressive course without diurnation. There are no history of trauma or operation, no history of diplopia or squint. She has been diabetic on insulin for 50 years, 15 years. Our system was irrelevant and no family history of ptosis or myopathy. On examination, the best corrected visual acuity was neither are at right eye was 6.9 and left eye was 6.6. Pupil was equal in size, center round, regular react to light, no rapid or light near disassociation. Motility shows there are restricted ocular motility in all direction of case, absent Bell's phenomena. And there are no improvement with Doll's eye movement. External examination shows there are bilateral severe ptosis. Reflex distance was -1. There was a poor levator function, about 2 millimeter. Anterior segment examination shows there are cortical cataract. Intraocular pressure was normal. Posterior segment show normal macula optic disc. Retinal vasculature, there are no evidence of retinal pigmentation or salt and paper appearance. So we start to put our differential diagnosis about this female patient with past history of diabetes and bilateral severe symmetric ptosis with poor levator function. There are bilateral restricted ocular motility with generalized fatigue and weakness. I started to put my differential diagnosis. I was start to think about some neurological element about oculomotor nerve palsy or supranuclear gaze palsy. I start to think about neuromuscular disorders such as myasthenia gravis. I start to bit about myopathic such as chronic progressive external ophthalmoplegia, myotonic dystrophy, and oculopharyngeal dystrophy. Third cranial nerve palsy actually was excluded because there are no lack of pupil affection, absent of characteristic pattern of eye deviation, which is outward and downward, being bilateral and symmetrical, which is very rare when you are see bilateral third cranial nerve palsy. So pernuclear gaze palsy, which is showing a vertical saccadic velocity slowing, especially affected down gaze, and it's then it's complete affect the upper gaze, and later on the horizontal gaze is affected and developed a complete ophthalmoplegia. But as I said, and during examination, dull eye movement did not result in improvement of ocular motility of patient, which is characteristic to supranuclear gaze palsy, which is bearing the vestibular ocular reflex. So it was excluded because there no improvement in with dull eye movement. But myasthenia gravis, actually, it's there are no variability of symptoms during the day, negative lid fatigue test, and absent Coogan eyelid twitch sign. There are negative eye speck test. Serum antibody anticholinesterase actually was negative, and it's repeated by another doctor twice. They are cannot. They think it must be myasthenia. This pattern and with generalized fatigue, it must be to be myasthenia, but it's the investigation repeated twice and it was negative. About myotonic dystrophy, it can come form in different forms such as congenital, during childhood, during adult. With myotonic dystrophy, beside external ophthalmoplegia, there are lead legs, there are characteristic cataracts, hypertonia affecting the hand of muscles, and it was absent in our patients. There are no family history, no Christmas tree cataract, no slow releasing grip, and no retinal pigment dystrophy, so I exclude myotonic dystrophy. About oculopharyngeal dystrophy, it is autosomal dominant patient, older patient as fifth decade. In addition to external ophthalmoplegia, a bulbar symptom with dominant features such as dysphagia, and weaken our teres muscle. So it also was excluded due to lack of family history and absence of bulbar cyst. So we can conclude that our patient has a chronic progressive external ophthalmoplegia. Actually, chronic progressive external ophthalmoplegia is slowly progressive course disease, and it's make its causes which cause acute and subacute or static form of ophthalmoplegia. Chronic progressive external ophthalmoplegia, usually it is pupil, and the patient, as our patient is presented with ptosis and ophthalmoplegia is sparing pupil. It's most common in third or fourth decade of life. Our patient is 39 years old. It's bilateral and symmetric involvement of both eyes without diplopia. Despite there are severe defect in ocular motility, there are no diplopia. Investigation, actually, chronic progressive external ophthalmoplegia is a clinical diagnosis. You can depend on history and examination to diagnose it. Some papers said their serum lactate and the creatine kinase was elevated in serum and CSF level, but is neither sensitive or specific for chronic progressive external ophthalmoplegia. Also, absence of anticholinesterase antibody and the thyroid autoantibody in evaluation of patient with myasthenia gravis or thyroid or disease. We may be used as our patient. We make test for anti-acetylcholinesterase. But about thyroid, actually, long-standing thyroid cases can be associated with a fibrosis of muscle, and it can be give picture look like chronic progressive external ophthalmoplegia, but usually it's associated with apoptosis and lid retraction. In our patients, there are ptosis and severe ptosis. In some patients, when history and the examination, you can't reach your definitive diagnosis, you can depend on muscle biopsy. Actually, this first picture from above, it is a normal muscle biopsy. In the chronic progressive external ophthalmoplegia, it looked like reg, muscles fiber. In the Kearns-Sayre syndrome, which is a variant of chronic progressive external ophthalmoplegia, it usually presents in younger age. It's associated with another systemic manifestation, as we will see next in our presentation. It's characteristic by its absent red fiber, and there are absent of cytochrome C oxygenase. Myotonic dystrophy bar also is associated with internal nuclei. In some cases, when you have you can make a genetic testing for to confirm a diagnosis and to know a prognosis of case. Actually, why extraocular muscles is affected in this systemic disease, يعني chronic progressive external ophthalmoplegia, it's a mitochondrial disorder. Why it's mainly affect the extraocular muscle? Up to 60% of mitochondrial chronic progressive external ophthalmoplegia is about abnormal mitochondrial DNA. It may be inherited from mitochondrial DNA or from a nuclear DNA, which can affect mitochondrial DNA maintenance. It may be familiar with autosomal dominant or recessive pattern due to nuclear DNA mutation or sporadic cases. Enzyme coded by mitochondrial DNA, it has active role in oxidative phosphorylation, and the extraocular muscle have adapted to have higher both mitochondrial content and the metabolic demand compared to skeletal muscles. So this is theory, the mitochondrial DNA abnormality will be more pronounced in the extraocular muscle due to high content of mitochondrial and high metabolic demand. So in chronic progressive external ophthalmoplegia, usually the extraocular muscle will be affected. There are terms called chronic progressive external ophthalmoplegia plus syndrome. As I said, chronic progressive external ophthalmoplegia is a mitochondrial disorder. It can be presented as isolated disorder or the part of syndrome with multi-system involvement. Frequently, patients suffer from exercise tolerance and proximal limb weakness, which explain why our patient, which present with ptosis and ophthalmoplegia, she has a generalized weakness and fatigue. Also, chronic progressive external ophthalmoplegia can be associated with many other symptoms, which is called ophthalmoplegia plus syndrome. It's result from all over mitochondrial abnormality all over the body, can affect CNS function, can affect the GIT, can affect the hearing deafness, can affect cardiac conduction defect, endocrine dysfunctions such as diabetes, musculoskeletal and cutaneous abnormality. There are many syndromes such as mitochondrial neurogastrointestinal encephalopathy syndrome. Besides, there are chronic progressive external ophthalmoplegia. Patient present with pseudo obstruction and mixed demyelination and oxygen neuropathy. There are some important tips is they are different in mutation load between the patient. So the presentation was not typical all over the patient. Some patient present with severe manifestation due to high mutation load. Some patient will present with small manifestation or mild manifestation due to small mutation load. Treatment, there are no definitive treatment for chronic progressive external ophthalmoplegia. Usually, management was supportive. In this patient, we plan to repair ptosis. Ptosis can be repaired as ordinary ptosis, such as severe ptosis. We can make a sling operation, but the patient during examination she has a poor or absent pupils phenomena, so it's absolute contraindication because it has a risk for exposure keratopathy. My home message is that chronic progressive external ophthalmoplegia is a clinical diagnosis. Patient in which presented with a progressive external ophthalmoplegia with ptosis. Most of patient has a generalized weakness. Review of other system is important to exclude chronic progressive external ophthalmoplegia plus syndrome. ECG is mandatory to all chronic progressive external ophthalmoplegia patient. Our patient was sent for cardiac clinic and they make ECG which was normal. Take care and do surgery as a Bell's phenomena is always lost in this patient. I want to thank Dr. Mariam Abul Fadl, senior ophthalmology resident. She helped me a lot in photography and preparing this case. Thank you.
شكرا دكتور صلاح for this interesting presentation. أنا بس عندي سؤال ليك، إيه المود of inheritance of this
maybe